that was buying us time, and hopefully you learned something too while we transition. So the Nebraska team's up. Who's going to be presenting?
Eve will be presenting.
Okay, you can go ahead and share your slides whenever you're ready.
Hello. So we are the team at the University of Nebraska. Let me go ahead and share my screen here. All right. Our pitch is on hypertension and the diagnosis in African Americans. And the team is composed of Mrinal and Garrett, both PhD students in computer science from the University of Nebraska-Lincoln, or UNL. A Queen, who is a medical student at the University of Nebraska Medical Center, or UNMC. Tom, from the Center for Intelligent Healthcare at UNMC. And I, Eve, PhD candidate in biomedical informatics from UNMC. Our faculty advisor is Dr. John Window, Holland Distinguished Chair in Cardiovascular Sciences and the Director of the Center for Intelligent Healthcare. Next. As a preamble, here are some key facts. Blacks or African Americans have been disproportionately affected by hypertension. 66 million Americans are diagnosed with hypertension. And based on the American Heart Association, American College of Cardiology, and the Centers for Disease Control and Prevention, 20% of all American adults with hypertension are undiagnosed, and that amounts to 73% of Black adults. Hypertension accounts for 5,000 annual deaths in America, and hypertension in African American carries twice the cardiovascular mortality and 5 times greater risk of heart failure. Of importance, for any one blood pressure measurement confers a much greater risk of death and disability to African Americans than to any other race or ethnic group. For instance, a blood pressure of 140/90 increases mortality by 24% in Blacks versus 8% in white. Next. And so our presentation will have 5 main points. We will give a background of the problem statement and then present the solution and how the solution should work in a real-life clinic setting. Then we will cover the data set we intend to use and the features thereof, and talk about the challenges we must overcome to bring our solution to fruition. Next. So the HAA-ACC state that the situation of hypertension under diagnosis is due to inaccurate diagnosis, which lead to poor control and management of high blood pressure. And Health and Human Services developed the concept of hiding in plain sight, or HIPS. And HIPS detecting algorithms was developed and led by the National Association of Community Health Centers. It lays out steps and identification criteria for patients hiding in plain sight, meaning those with undiagnosed hypertension. From a longitudinal study conducted from 2014 to 2016, HIPS reported that as high as 73% of Blacks were undiagnosed compared to other groups. More recent data show that only 48.5% of African Americans have their blood pressure under control, and that is in comparison of 58.5% of white patients. And the difference in hypertension control is particularly significant because the attributable risk of hypertension and 30-year all-cause mortality is almost double in Blacks compared to other ethnic groups. Next. So hiding in plain sight is good at identifying undiagnosed groups, but there is still no solution to the biases and disparities in the actual diagnostic process. And as per healthypeople.gov, health disparity is a health difference that is closely affecting people who have experienced a greater obstacle to health based on several socioeconomic, demographic, and physical factors, including race and ethnicity. And based on this definition, it is clear that African Americans are experiencing health disparity with respect to hypertension diagnosis, control, and management. Next. So to address the disparity of hypertension diagnosis in African Americans, we propose a strategy of using home blood pressure monitoring linked to machine learning algorithms. Our algorithms will map clinical performance measures to the output because a recent report from the I.AIM advocates for more initiatives that can bolster a wider adoption of hypertension performance measures in clinical care. So our solution will automatically report these measures to keep clinicians abreast of how they are doing based on the underlying data and the number of diagnosed patients in the different hypertension stages as per the 2017 hypertension guidelines. Next. So since our algorithms will be designed in accordance with the I.AIM guidelines and will automatically report the performance measures, they will drive accurate diagnosis and treatment to target, not only in our target group, but also in the population at large. The machine learning models will include the probability graphical model using a dynamic Bayesian belief network and the recurrent neural network, both of which are well suited for time series data and thus will best model the variations in blood pressure. The dynamic Bayesian belief network will allow us more control in modeling additional probabilities between the features based on expert input. So it is an approach that will be more comprehensively adapted to the I.AIM guidelines. It can also lead to explainability in the predictions, allowing clinicians to justify their decisions confidently. The recurrent neural network model will allow us to have a benchmark against which to measure whether the custom modeling of conditional probabilities with the Bayesian belief network yields better results. In the end, we'll retain the models with the best performance on the test set. Next. So as an adaptive decision support to clinicians, the best models from our solution will run regularly to make diagnostic inferences based on data points from outpatient clinic visit and home blood pressure measurement transmitted by patients. The predicted diagnosis will be integrated into clinicians' workflow via FHIR protocol by reporting them on Epic's Hyperspace dashboard or other EHR system dashboard from any vendor. So our solution is vendor agnostic. We'll assume that at the upstream, our patient at risk of developing hypertension will be provided blood pressure course, and this can be done via recommendations sent by their primary care provider. The initial data set we are going to use is from UNMC and is composed of more than 4.8 million blood pressure readings from 418,072 patients, among which 50,223 are African Americans. We'll also collect blood pressure readings from home blood pressure course, which will be automatically transmitted as CSV files to the electronic medical record via FHIR protocol. Next. To determine hypertension status, the algorithms we will develop will learn from features such as obesity, renal failure, the incidence of ICD-10 hypertension diagnosis, and the rate of hypertension medication prescription. Obesity will be determined by a BMI greater than or equal to 30 kilograms of body mass divided by the square of the body height. And renal failure will be determined by an increase of serum creatinine levels of over 0.3 milligrams per deciliter of blood. And to account for wrongly recorded blood pressure measurement, the I.AIM recommend considering only measurement taken 2 or more times on 2 or more occasions. Hence, the features will include the number of times and occasion the measurement were taken. The algorithms will also learn how hypertension diagnosis is associated with demographic features, notably race and ethnicity, as well as age. Next. An ethical issue we have to address is providing proper access to health-protected information to team members. The Collaborative Institutional Training Initiative program has a module on health privacy that covers patient right to be notified of privacy practices, as well as access to an amendment of medical records. Each team member will be required to complete this module and present a certificate before accessing the data. A technical challenge is that of scalability of our algorithms to to ensure the algorithms generalize well to the data from other clinics and medical centers across the country, we will seek external data set on which to retrain our models. If the external data set is found after the models have been trained on our internal data set, we can apply transfer learning when retraining our external data set to ensure the models don't start learning from scratch. And here, expert.ai NLP tool could also help us extract features from the external data set, since it is not sure this set could be found in a structured format. Next. So in conclusion, hypertension disproportionately affects African Americans, and there are ways to detect the underdiagnosed groups, but there is no established solution for a more accurate diagnosis. We propose to develop algorithms that will be modeled after the I.AIM best practices to diagnose hypertension, taking into account the observed disparity based on a careful selection of features with the help of medical experts, including our faculty advisor. Thank you.
All right,
Is
nice
it time
work.
for questions?
It is time for questions.
Okay, great. A very good presentation. Thank you. My question is for the, we're getting in all this data, the hypertension data, the indicators. Can you speak about the feedback mechanism for the patient or the, for the patient? Where is the connection between the data that's being received on the clinical end and the diagnoses and the actual intervention that will prompt the individual to take measures to address the hypertension?
For this part of it, we are going to distribute these blood pressure cuffs that we have two different models that we would utilize. One of them if the patient has a smartphone, and one of them if they don't. The one if they do not have a smartphone would connect to a little router that is connected via satellite internet that would connect to their blood pressure cuff and then directly inform our database and our machine learning systems. And the other one would be through a smartphone. And I just want to make sure that we're clear on this, is that we're trying to, we would distribute it to mostly African Americans because we want equitable health data, not just, we don't want to just distribute it to a population that's representative of our existing data set, because as Dr. Evans pointed out, like there are health system factors that really contribute to these disparities. And so we only use the clinical data that we have existing after we know that African Americans are underdiagnosed and aren't being treated to target as well. That would be a real act of negligence, I would say. And so we would definitely, to get the data in a more equitable way, definitely would try to have as many in-home blood pressure readings. And so we target African American populations to get these blood pressure cuffs. And so they would connect there, and then using a FHIR protocol, we would connect it through, and it would show up on our clinician dashboards with the clinical support system that Eve has been building.
I have a question. Okay, hi. So your thesis is that there's underdiagnosis, yes, and you're going to try to get some data by giving this remote patient monitoring, doing this remote patient monitoring into a specific, African American population. So then I don't understand what you're doing, because you're saying there's underdiagnosis, so we're going to overdiagnose compared to the population, this one population. And then what's the point of your AI then? I mean, I don't get, all you're going to do is you're going to put more cuffs in a population that is underrepresented with cuffs, with measuring. So I don't see what you're going to prove.
Thank you very much for the question. Garrett, go ahead.
Hi, thank you for the question. I just want to say that I don't think there's going to be any final like single solution, single data set, single model solution to this problem, because we have clearly very different rates of diagnosis that are probably caused by different factors among different populations. We do know that we've got a population that is suffering from a severe underdiagnosis. So the solution to that problem is not to overdiagnose among that population. It's to generate good data there that's accurately diagnosing that population that we could use to train a model that would become part of a larger ensemble of models to accurately diagnose the general population.
Yes, because based on data from the SCC, they reported in 2019 that from the population at large, 20% of adults with hypertension are unaware of the condition. So there is already, with the standard of care, there is already a gap in the, so they're missing out some of the patients. They're not being accurately diagnosed. And then now the HIPS algorithm from the CDC also showed that now 73% of Black in the Black population are also unaware. And so what we're trying to solve here will help. It will not just help to bring up the numbers of accurately diagnosed into the Black population, but also in the population at large. And our algorithms, so based on the features modeled after the I.AIM, will help. So it will be like a second tool to support the current standard of care, which is the ICD-10 coding and documentation. And so there is really a need for a tool that can help already, I mean, given all the fact about hypertension. And then there is particularly a huge need for the African-American population.
If I could clarify my answer very quickly, it kind of relates to the machine learning concept of boosting algorithms, where you train a model, it performs well on most of your data set. And then for the things that you're not performing well on, you just take that out, train a model on that data set, try to do well on things that you're not currently performing well on. That's kind of what we're trying to go for here.
And actually, I was going to add to that. I'm a little still confused and also a little concerned, because it seems like you're going to identify an at-risk population based on diagnoses, obesity, and some other factors. And I do wonder if maybe sometimes the population for Black patients in particular tend to be younger or have other, kind of risk factors that are not diagnosed. And so this model could fail to identify that population. That if you're undiagnosed for hypertension, you're likely undiagnosed for other conditions as well, which means this identification plan might not really work that well. And I guess my other concern is, so you send people blood pressure cuffs in the mail, are they gonna know what to do with that or understand like what the point is? Like, how are you gonna get to people to actually do this?
So it would be we would not send them the blood pressure cuffs in the mail, but that is a good observation that we didn't exactly clarify how we would train them through their primary care physician, since there is a real gap not only of access of healthcare but access of specialty care, and so not so Black populations are less served by the healthcare system overall, but especially in specialty medicine. And so by addressing it at the primary care level, we'd be able to increase the access of that sort of data that gets sent to cardiologists. And I completely agree with you that it's a massive problem to diagnose, and the underdiagnosis of so many different diseases, and it's just a massive public health problem. And we're just trying to take a little snippet and just chip away at that.
How are you recruiting the subjects that are going to be a part of this this study? Of getting the blood pressure cuffs and providing information, and also hypertension is a comorbidity to so many other. I mean, you kind of talked about that a little bit, but it's a comorbidity to a lot of different things. And so, how do you stratify or isolate who should be subject to this particular intervention?
Tom, can you get that? So I think here specifically we are talking about the different groups which are affected. We are considering, I mean, so based on the features first, we are considering the ICD-10 diagnosis, and then we are also considering those who are on medication. So people can be on medication due to another condition, but that medication is also helping with hypertension. And so they may be undiagnosed with hypertension, but being treated for another condition. But when we look as part of our features to the rate of medication prescription, we can identify, we can capture those with hypertension being treated for other condition, but being provided a medication helping them to not be captured in the current standard of care. So it's not documented on their problem list, but it's a problem that they do have. So there's so people with high blood pressure as well, who are going without being captured. So when we look at working now with their primary care providers, we can so the provider can give a recommendation for blood pressure cuffs, and at that point they can transmit that data to the system as well.
Yeah, and so we have identified a limitation is that we would only be capturing patients that are already in the system, and that is a real limitation. And in terms of the hypertension medication prescription that we look at, it would be through RX class, and it's an ATC code, and I think it's C02. I apologize, I don't have it in front of me, but that would wrap up all of the alleviating and aggravating hypertensive medications, and so we have that considered in our algorithm. And the key is these blood pressure cuffs would not diagnose any. It would just help feed the algorithm to improve it, so that we'd have a real clinical decision support system that can aid clinicians in communicating better with their patients, because it's really about getting that. It's just another level of communication between clinician and patient and the health system at large that we're trying to foster.
Great. So I'll cut it at time. Great discussion. Thank you guys for taking the time. Really appreciate the presentation very much. And so I think next team up is Penn State. So Penn State Nittany Lions.